This week on the BackTable podcast.
When I was a trainee, we had to really push to get neoadjuvant chemo and almost never were able to get our medical oncologist to give it in this space, so before POW trial data. Now, I think it's more of a conversation, and it's a conversation with the medical oncologist and the patient. I lean towards neoadjuvant chemo as much as I can encourage a patient to do it. I think that that's the right setting to get the therapy to the patient. I worry about that 30% of patients who will become ineligible for adjuvant therapy based on that loss of a renal unit. So my personal preference is always to encourage neoadjuvant therapy, just send every patient in this setting to a medical oncologist to discuss exactly what that looks like and really emphasize to the patient that I think this is the time to get that therapy in. But institutionally, and obviously every patient will make a decision based on what makes sense to them in that moment, especially when you take care of patients from far away. Sometimes they come in and say, I just want my surgery. I'll deal with it later if I need to. It's always a patient-specific decision, but my personal preference is for neoadjuvant.
Hello, my name is Nirmish Singla, and I'm a urologic oncologist in the Brady Urologic Institute at Johns Hopkins. It's my honor and privilege to host today's discussion on upper tract urothelial cancer. This is actually part of a larger tumor board series that's co-hosted by BackTable Uro and the Young Urologic Oncologist section of the Society of Urologic Oncology. So thanks to both the SUO and BackTable Uro for allowing us this platform. Today, I'm joined by two esteemed guests. Dr. Jeannie Hoffman-Censits, who's a medical oncologist here with me actually at Johns Hopkins and co-director of the Upper Tract Urothelial Cancer Program and Multidisciplinary Clinic. Dr. Hoffman-Censits, welcome.
Thanks for having me.
Absolutely. And also on the other side of the country, we have Dr. Bogdana Schmidt, who is a urologic oncologist and also an expert in urothelial cancers. And we are very fortunate to have both esteemed guests join us today. Dr. Schmidt, again, thank you for being here with us today.
Thank you so much. I'm looking forward to the conversation.
Absolutely. And so am I. I think what I've done for today is I've assembled four what I would consider to be real world cases, real cases that have come across our practice here. I think summarize many of the nuances and challenges that we may face in upper tract urothelial cancer. And I think this would be a great opportunity to gain some insights from experts in the field, both Dr. Hoffman-Censits and Dr. Schmidt, to hear how you would manage these complicated scenarios and to hear some more of the contemporary evidence in UTUC. So without further ado, let's get started with our first case. This is the case of a 66-year-old male, no remarkable history, who in 2012 had undergone a right distal ureterectomy and reimplant for ultimately a moderate-sized tumor that was TA low-grade upper tract urothelial cancer. All margins were negative. 11 years later, during surveillance, he was found to have a new filling defect in the right or ipsilateral renal pelvis, as you can see here on the cross-section in a delayed view. He underwent a ureteroscopic evaluation that revealed a sizable tumor within the renal pelvis and a biopsy that was acquired that revealed low-grade UTUC. He has fairly decent performance status and his GFR is 85, most recent creatinine 0.97. So Dr. Schmidt, I'm going to pitch this one to you. With this information, how would you counsel this gentleman on his options?
Yeah, so I think in general, this patient is in a relatively favorable position. So he still has good kidneys on both sides. He's overall healthy. It took him 11 years to recur. So you think this probably is not a tumor with a lot of aggressive features, no high grade found. So I think this person has options. Certainly more aggressive treatment would involve nephro-U. I probably would lean away from starting with that. But you have a local treatment option, so laser ablation, whether that would be retrograde laser or PERC ablation. Can consider some focal treatments like gel-mito or reverse thermogel mitomycin. Could be an option here. I would probably not use BCG in this setting. I think this is a conversation with the patient saying, like, there's a couple different ways you can approach this. I probably would not start by removing the kidney, and then very, very careful surveillance with any endoscopic approach, making sure that we continue to monitor. So if it were me, I'd probably start with a laser ablation, just looking at the location of it. I'd probably start retrograde, but certainly you could perk into it. Looks like it's about 1 centimeter, maybe 1.5 centimeters. So I think retrograde's reasonable. Anything over 2 centimeters in the pelvis, I think maybe a PERC would be better. And with respect to laser, I mostly have access to the holmium. I've tried the thulium before. I like it a little bit more. I think the coag on it's a little bit nicer. I think the tumor ablation features are a little bit better. But in my practice, I have to borrow that from my benign colleagues, and sometimes I can, and sometimes they're using it. So holmium works just fine. I use low settings, 0.2 and 50, and kind of go to town.
That's really excellent. Excellent overview, very comprehensive discussion of the different options. It sounds like with the low-grade diagnosis, you'd be very comfortable with a nephron-sparing approach rather than jumping straight to a radical nephroureterectomy. I actually share the same sentiment when it comes to the choice of laser. We also have the luxury of having access to thulium. And I personally have found as well that the coagulative properties of the holmium laser, particularly for fulguration of upper tract tumors, seems to be a bit more hemostatic in nature compared to the holmium. So I feel like I tend to buy more time with the fulguration approach, especially for larger tumors. And if this patient were to have an incomplete treatment session, or if this patient had recurred again with, let's say, low-grade disease in the same spot, Dr. Schmidt, would you consider repeating the same type of an approach? Would that push you more to consider something like gel-mito?
I would consider it in the adjuvant setting. Yeah, I think I would go back in. I'd try to get rid of as much tumor as possible, and I would consider the gel-mito. I would do it antegrade, so patient would need a nephrostomy tube. I think I worry about the stricture rate using it in a retrograde fashion. So as long as the patient lived nearby where he could get a nephrostomy tube, come in for 6 weeks at a time where we could take care of him that way, then I would definitely consider antegrade gel-mito. If you look at their data, the patients that respond, the durability of response is quite good. I think you're looking at 80% at a year of the responders. That's quite favorable. But again, with any endoscopic approach, I'm very vigilant about going back in every 3 months, which is a real challenge with the anesthesia risk to these patients. You have to consider it. But I worry a lot about these tumors growing back and just sitting on them.
Absolutely. And I share the same sentiments. We, when it comes to gel-mito, also tend to utilize an antegrade approach. But the ureal stenosis, it is a real phenomenon, both anecdotally and as we can see from the literature. In terms of durability, actually, just hot off the press in this month's Journal of Urology, you may have come across, there is the long-term follow-up from the Olympus trial that was just published, which seemed to show, just like you said, fairly durable outcomes with the use of gel-mito. So it's certainly a fine balance. In terms of how this patient did, ultimately, we went ahead and just treated him endoscopically. We used the thulium laser fiber. He did require 2 sessions to fully treat and debulk the tumor. Some of you can't really appreciate it so much in this single cut, but there was some lower pole component of the tumor that was a little bit harder to access initially. But after 2 sessions, we continued to monitor him at 3-month intervals. And now, since from his most recent fulguration session, he has been NED for 12 months. And so hopefully this is a testament to the relative indolence with respect to the natural history of low-grade disease.
I will point out that right now, one of the challenges with low grade, right, is we are so reliant on our whether imaging with CT urogram or just direct visualization with repeat trips to the OR. What I'm really looking forward to is some of these urine-based assays that can be helpful in this space. Right now, that's a space that's growing, certainly nothing out there right now, but I'm looking forward to that in the next couple of years, whether it's for high-grade or low-grade disease, to see if we can potentially stagger our direct vision looks with maybe a urine-based assay. I think that would help these patients quite a bit, because I think we obviously, for our own fears, overlook, meaning check too many times.
Absolutely. And I think, especially when it comes to undergrading limitations, multiple large series may report even as high as a 50% undergrade discordance between biopsies and final pathologies. And so I share very much the same sentiment that urine-based tests may be the way of the future. The last, I'll just put a plug out for a clinical trial that is also in this space. I think kudos to the Olympus Trial Consortium for being able to achieve FDA approval for an agent in the low-grade UTUC space, let alone complete a clinical trial. But there is also a phase 3 trial called the Enlighted trial. It's also actually part of the SUO-CTC, and it's investigating a novel approach that leverages something called vascular targeted photodynamic therapy, or using something called pataluporphin or TUCAD to, in a more direct manner with a certain wavelength of activation, essentially have a targeted approach to treating certain tumors. Certainly very encouraging results that were published recently from the phase 1 trial of this, and we're eager to see the results from the phase 3 trial once they emerge.
And Nirmish, this is the one where you have to give them something IV, right? A tracer IV, and then you bring kind of the laser fiber intra-op and you shine the fiber on the tumor?
That's exactly right. And the laser itself activates at a very specific wavelength that would then activate this compound called pataluporphin to induce necrosis within that region. And so that exactly is the concept behind it. And it'll be very interesting to see the data once it comes out.
Absolutely. And given how rare this disease is and how much data we need in this space, open the trial, enroll your patients, change the future.
Can't say it better. Wonderful discussion. Thank you, Dr. Schmidt. Let's move on to our second case. I know we have a lot of excellent points to cover today. For our second case, we have a 73-year-old gentleman, history of atrial fibrillation, who had gross hematuria, for which he underwent both cystoscopic evaluation and cross-sectional imaging. As you can tell from these areas highlighted from these single cuts, on the left side, he was found to have a filling defect that spanned a decent portion of his both mid and distal ureter. Overall, he had a reasonable performance status. His GFR was 58. He underwent a ureteroscopic evaluation that revealed extensive tumor, again, spanning throughout the distal and mid-ureter circumferentially. A biopsy was acquired. The interpretation of the biopsy was that it was consistent with high-grade urothelial carcinoma. There was some suspicion for lamina propria invasion. Before I jump into the options, maybe another question for Dr. Schmidt. Maybe, we see this when it comes to kind of understanding the depth of invasion on these pathology reports. In this case, there's some suspicion for lamina propria invasion. I would be curious to know how you would interpret this. Do you consider this to be a T1 tumor just based on this pathology report? Is this something that you feel confident in?
Yeah, this is the bane of all of our existence, right? So these ureteroscopic biopsies are notoriously challenging. I think our ability to get to the depth of the tumor is very limited by the equipment that we use. So for me, if it's a high-grade tumor, I almost never believe the path that I get, and I almost always think it's worse than they say it is. So if they say it's suspicious for lamina propria invasion, in my mind, it's for sure at least lamina propria invasion, with the concern that this might actually be T2 in reality. I've toyed around with the different biopsy techniques and different tools. So I used to use the bigopsies exclusively, which I hate, but I think they give you a better sample. I've transitioned somewhat now to using an alligator forceps, and I do the biopsy a little bit differently. So I was taught to do it kind of a slow pull technique, right? So you grab it and you pull until you get it off. And now I've started doing a forward push technique. So you grab it and you kind of try to shear it off by pushing it with the ureteroscope forward. I find that you get that lining a little bit better to get that depth. But to answer your question more directly, that's suspicious for lamina propria invasion makes me worried. It's at least T1, likely T2.
And Dr. Hoffman-Censits, this patient had undergone a staging evaluation that revealed no clear evidence of radiographic metastases. With this information, is there a role for a medical oncologist to be involved in this patient's care? Maybe can you comment on whether there's any role for example, perioperative or for systemic therapy at all?
Yeah, absolutely. I think a few things with this case. So first, it really highlights who are the patients that are walking into our clinic, and they are that kind of average 73-year-old patient with a host of medical comorbidities that maybe potentially can complicate, the administration perioperative therapy, atrial fibrillation on Eliquis with bleeding, and then thinking about, giving the chemotherapy that can cause thrombocytopenia. It can be a little bit nerve-wracking, but in general, with hydration and oftentimes some early clinical benefit that we can see, that's often not too much of an issue. I think from a medical oncologist standpoint, seeing a patient like this in clinic, especially if this is not a common consult, I think one of the points that was brought up earlier about staging, I think we, as med-oncs, we're pretty comfortable seeing patients with the same disease, a few inches south, muscle-invasive bladder cancer, and knowing that there's level 1 evidence to give platinum-based chemotherapy in the pre-op setting, but maybe potentially not as familiar with the fact that it's really, really challenging to get adequate biopsies. And in fact, going back, as you mentioned, again and again, to get more biopsies to feel more comfortable with this diagnosis can in fact hurt the patient, or maybe even cause a renal stricture and renal insufficiency down the line. So, in our practice, this is actually completely like what the information we would need in order to treat this patient, or at least to discuss a perioperative therapy. There's a few trials now, 2 trials, one the ECOG 8141 trial, as well as Jonathan Coleman's preoperative study, both using cisplatin-based chemotherapy and showing what we had seen in some previous historic studies, that platinum-based chemotherapy can be safe in appropriately selected patients and get them to a point where there's a percentage, somewhere between 14 and 19% of patients, that can be significantly downstage to a CR at the time of surgery, at the time of nephroureterectomy. And it does seem to be those patients that, just like those with muscle-invasive bladder cancer, tend to ultimately do better. Looking at this case with this patient with a GFR of 58, with looks like 2 functional kidneys, I would be concerned that this patient has kind of one shot on goal to get platinum-based chemotherapy safely. And I think that would be in the pre-op setting before that kidney came out. Sometimes it's not the case. Sometimes, we're talking about a kidney that's been atrophic, potentially because of obstruction for years. But I think in this case, I would, as long as the other medical comorbidities that we think about when we are counseling patients about platinum, so do they have peripheral neuropathy? Is their cardiac function okay? Can they handle the volume of IV fluids that we give with the chemotherapy? Do they have peripheral neuropathy, hearing issues, those kinds of things? But as long as the patient is a candidate, I think it would be reasonable to consider neoadjuvant chemo. We actually do have a large-scale randomized phase 3 trial going on in the Barber group setting right now. It's ECOG 8192. And that trial randomizes patients like this to MVAC chemotherapy for 4 preoperative cycles versus MVAC plus durvalumab. So that study might be open at a cancer center near you. And in fact, this pathology would meet eligibility criteria. So really, in the upper tract setting, we're really not expecting to get muscle-invasive samples. So any high-grade sample with a visible lesion on a biopsy specimen or on a radiographic scans would fit those eligibility criteria. If this patient came to us and had these scans but went straight to surgery and had a high-risk tumor, so in upper tract cancer, we're talking about a pathologic T2 or higher, or with lymph node positive disease, if they were still a platinum candidate, of course, the PALT trial showed that platinum-based chemotherapy was beneficial in the postoperative setting and improved disease-free survival. There's a follow-up that was recently published about a year or so ago in the JCO with longer follow-up. So adjuvant chemotherapy for the high-risk patients post-op, absolutely an important tool in the toolkit. I think the challenge with our population of patients in the upper tract setting is how much platinum can they get and whether or not they're eligible for cisplatin. In the PALT trial, patients could get carboplatin if they were not cisplatin candidates, mostly based on renal function. And a lot of people actually had to transition from cisplatin to carboplatin in the postoperative setting in that study. So that's another option if the patient had worrisome pathology. And then finally, we also have 2 positive immunotherapy studies in the adjuvant setting. So those studies were both designed for patients who had high-risk urothelial cancer, and in about 20% in the patients in both the adjuvant nivolumab and adjuvant pembrolizumab trials had upper tract tumors. So either patients who had preoperative platinum-based chemotherapy or for patients who were not eligible for platinum pre or post-op. They were randomized to a year of adjuvant checkpoint inhibitor versus either placebo or observation alone. And both of those studies were positive, and so adjuvant immunotherapy is a tool that we have in our toolkit. It seems interesting in both studies. In a subgroup analysis, it seemed that even though the intent to treat population, which included all patients in those trials with lower tract disease and upper tract disease, but those studies both met their primary endpoint in terms of disease-free survival. It seemed like those with upper tract disease potentially are not getting the same benefit. We don't have discrete data on why that is. We also know that at least from the nivolumab trial, patients who also didn't have a lymph node dissection and also didn't have neoadjuvant platinum-based chemotherapy and also had impaired creatinine clearance may not have gotten the same degree of benefit. Whether or not those patients happen to also be more represented by those with upper tract disease, it's hard to say. We don't have that information. But I think in the perioperative setting, there's certainly room for discussion with your local medical oncologist and treatment options that we have for these patients.
Can I hijack this for just 1 second? So you brought up something that I struggle with in this setting exactly. So the Ambassador trial, nivolumab adjuvant, really did not, in a subgroup analysis, demonstrate a benefit. So when you have this clinical scenario, right, that patient that goes straight to surgery, we know from POUT that there was a benefit from carbo. And we don't have convincing evidence that there was benefit from immunotherapy. Obviously, immunotherapy patients look at more favorably. Carbo is generally well tolerated, but in that cis-ineligible patient now, what do you lean towards? Do you still go for carbo per POUT, or are you leaning towards nivolumab or pembrolizumab?
Yeah, I think that's where the conversation can get a little bit tricky. So one thing to remember is if you go to the eligibility criteria for those adjuvant trials, patients had to have either not been a candidate for adjuvant platinum-based chemotherapy, and that includes carboplatin, or refuse it. So how that conversation comes about is a different story. But so I always think about, well, if the patient was coming to me on that trial, what would that conversation look like? And I try and mirror that in clinic. At least in the adjuvant nivolumab data, those that had PD-L1 positive tumors maybe got a little bit more of a benefit. So if the patient is really on the fence, or you're really not quite sure if they're even a good candidate for carbo, sometimes I let that make the decision for me. But otherwise, I'm not checking PD-L1 status in order to make that decision. But it's tough. And again, none of these studies are powered to look for patients with upper tract disease. And tragically, none of the future adjuvant trials are including patients with upper tract disease. So we've got a lot of great adjuvant data going to be coming out in the next couple of years. But unfortunately, we're not going to have as much in the upper tract setting.
Thank you so much, Dr. Hoffman-Censits, for really taking a deep dive and summarizing the recent and emerging data pertaining to perioperative therapies in this space. As we've heard, it's a very nuanced space. Even compared to like muscle invasive bladder cancer, where maybe the role for the timing of systemic therapy in a perioperative space is a little bit more clear cut. Here, there are certainly nuances related both to baseline comorbidities in generally what's a more elderly population affected by this disease, in addition to what the implications may entail with removal of a renal unit surgically. And so then it becomes really a weighted discussion about, neoadjuvant versus adjuvant space, and then also transitioning from cisplatin-based approaches, which we know have nephrotoxic implications, to the utility of alternative strategies such as immunotherapy. I will also mention, since Dr. Hoffman-Censits didn't mention it, that she is the global PI on the ECOG Akron 8192 trial, and it was also for the 8141 trial. And so, I think we're certainly very excited to continue to see the data emerge, and with one of our leaders here on the call itself. Dr. Schmidt, just out of curiosity, is there, in your institutional experience, is there a greater inclination to the use of neoadjuvant systemic therapies? Are you finding that there's a little bit more of a mixed bag, or is there more of a preference towards the adjuvant setting?
I think that's a rapidly evolving space. When I was a a trainee, we had to really push to get neoadjuvant chemo and almost never were able to get our medical oncologist to give it in this space, so before POW trial data. Now, I think it's more of a conversation, and it's a conversation with the medical oncologist and the patient. I lean towards neoadjuvant chemo as much as I can encourage a patient to do it. I think that that's the right setting to get the therapy to the patient. I worry about that 30% of patients who will become ineligible for adjuvant therapy based on that loss of a renal unit. So my personal preference is always to encourage neoadjuvant therapy, just send every patient in this setting to a medical oncologist to discuss exactly what that looks like, and really emphasize to the patient that I think this is the time to get that therapy in. But institutionally, and obviously every patient will make a decision based on what makes sense to them in that moment, especially when you take care of patients from far away. Sometimes they come in and say, I just want my surgery. I'll deal with it later if I need to. So it's always a patient-specific decision, but my personal preference is for neoadjuvant.
And I think another plug too for some recently put together guidelines that were published in the Journal of Urology, again, led by many of our urology colleagues, looking at guidelines for diagnosis and management of upper tract urothelial cancer that did include recommendations for perioperative chemotherapy for high-risk patients with high-grade upper tract disease.
Yes, and that has actually helped us. We ended up discussing those in Tumor Board and saying, look, we've all been asking you guys to do this. Here it is in our guidelines. So absolutely.
Yeah, it definitely was a long time coming to finally have an actual guideline within the AUA for UTUC. And I think that's a great way to also recognize the nuances of UTUC as its own entity. So just switching gears here, we talked about the role for perioperative therapies. Dr. Schmidt, this one is more for you. Can you comment a little bit on how you would approach this patient surgically?
Yeah, so that looks like a pretty lengthy tumor, distal mid-ureter, so I wouldn't try a segmental nephron-sparing option in this case. I think this is a radical nephro-U. I think the guidelines actually spell out exactly how you should perform this surgery, so I'm a guidelines-driven surgeon in this case. I think you have to take the kidney, you have to do a node dissection, you have to do a real bladder cuff. And the node dissection in this case would be basically a unilateral bladder node dissection, and as well as everything that kind of tracks along that ureter. Probably would get all the nodes that are periaortic in this side. I probably wouldn't go intra-aortic caval for a more distal mid-ureteral tumor.
Excellent. And if, let's say, this were more of a just isolated to the distal ureter, would you consider something like a renal scan to make a determination between a radical nephroureterectomy versus a distal ureterectomy? Is there a role for that?
I think there is a role. I think about that sometimes, especially when you're making the decision for neoadjuvant and adjuvant therapy as well. I think that there certainly could be a role. If it's a smaller tumor, yes, I would consider trying to do a segmental case, certainly with concern for, needing to put the patient on dialysis. But we know these tumors can be really aggressive, and you don't want to under deliver for these patients.
Absolutely. So
I didn't mention, because I apologize, but I want to be totally complete. I do use intravesical chemotherapy in these cases. I know everyone's institution has a different protocol. I try to do it simple. I do it in the OR at the time of the surgery. I put it in immediately at the start of the case, and I start my surgery usually with the bladder cuffs. I kind of dissect around it, but I try to get that chemo in for an hour and then drain it out, get the bladder cuff, sew up the bladder, do the rest of the case.
Yeah, and it's great that you brought that up, especially that we know that there is an elevated risk of distal seeding antegrade into the bladder, especially with the manipulation surgically with these tumors. I certainly have a similar approach with installation intravesically at the beginning of the case, but there is certainly data that supports the utility of intravesical chemotherapy, at least in some regards in the perioperative setting as well. And you make excellent points in terms of a proper surgical technique and lymph node templates. So to sort of reveal what happened, so this patient actually was enrolled on the ECOG Akron 8192 trial. He was actually randomized to the chemotherapy arm alone. and completed all 4 cycles, followed by a left robotic radical nephroureterectomy. At the time, because of the span of the tumor that sort of included both the pelvic as well as the retroperitoneal parts of the ureter, the decision was made to do both a retroperitoneal as well as a pelvic lymph node dissection. His final pathology was favorable, YPT1, N0, high-grade UTUC, all 25 lymph nodes negative, margins negative, and he's now 12 months out from his surgery and remains NED. I think the one unfortunate thing is that he did have some worsening of his baseline renal function, as you can see from his GFR. And so perhaps the call of giving him treatment in the neoadjuvant setting was the right one, perhaps.
Yeah, and I think, honestly, that's a great outcome for a patient. He has enough renal unit to maintain his life off dialysis. Hopefully he stays that way. He's cancer-free.
Absolutely. And honestly, from a functional standpoint, he's living life as he was, prior to a diagnosis of cancer. So even in the absence of one kidney, even with the degree of CKD that he has, he's staying away from dialysis and he's maintaining a very happy sort of quality of life at this juncture. So I agree. We've been pretty fortunate, I think, I would say, with his outcome. So let's move on to case 3. This one, I'm trying to stump the chumps here. So hopefully we can get something a little more tricky for you. So with this case, we have a 57-year-old male. He has a history of hypertension, hyperlipidemia, relatively a clean slate of health. But he does have this history of recurrent urothelial cancer in various parts throughout his urinary tract. His urothelial cancer history dates back to 2019 when he was initially diagnosed with TA high-grade non-muscle invasive bladder cancer. This was treated with a course of BCG. Following completion of the BCG, he had been initially without any recurrences for the first 2.5 to 3 years, and then was found to have a focus of CIS within the bladder. For that, he received induction course of gemcitabine docetaxel and has been on maintenance treatments for 2 years. That being said, he did also in 2022, he was found to have high volume, high grade upper tract urothelial cancer within his right upper urinary tract and had undergone an upfront radical nephroureterectomy with a final pathology that had revealed PTA N0 high grade UTUC. 2 years later, he had redeveloped gross hematuria and underwent evaluation for this. Ultimately was found on ureteroscopy to unfortunately have a recurrence in his contralateral solitary kidney with high volume, high grade multifocal UTUC, both within the renal pelvis and in the proximal ureter. A biopsy, as with an earlier case, had suggested the potential for lamina propria invasion. Of note, given the span of his urothelial cancers, MMR testing was performed. This is actually something that we try to perform routinely, but on the actual tumor itself, IHC stains for these MMR proteins were all demonstrated retention of the protein itself. I don't have the greatest images to sort of highlight the degree of his disease. Unfortunately, there were no intraoperative photos or fluoroscopy acquired, but at least adjacent to the stent on these cross sections that you see here, the arrows try to do justice to the tumors. If you can make out some of the sort of this mildly enhancing area of tissue thickening, consistent with what was seen endoscopically as well. I should point out that he had good performance status and his eGFR was 59. So with this situation, solitary kidney, high volume, recurrent, high grade UTUC, maybe I'll initially pitch this one to Dr. Schmidt. Can you provide us with some of your insights as to how you would approach this patient and counsel him on his options?
Oh, this is so rough. I mean, this is just one of those scenarios you really dread. First of all, this is a patient, obviously, I would look at genetic testing for, making sure that we don't have a Lynch scenario. You mentioned MMR or IHC staining, but just doing full evaluation for that, I think, is important. He's got a solitary kidney. He has a history of bladder cancer. I really worry about this patient. Obviously, you take out that kidney, they're committed to dialysis. I've had a patient like that recently who chose that route and said she wants to avoid systemic therapy, would rather go with surgical therapy. I think that cuts off your options down the line for some systemic treatments. Not having any renal units, you can only get Pembro at that point, maybe. Not even, right?
No, I would actually say no. it's easier to actually give systemic therapy once a patient is on dialysis. This creatinine clearance is okay, but if somebody had end-stage renal disease with a creatinine of, the clearance of 10 or 15, that's where it's much harder. So this setting would be more reasonable.
So, obviously that's still an option. I think that's a real discussion with the patient. I think I would consider systemic therapy in this patient while you can with that renal unit, especially given that you describe a fairly extensive tumor. I worry about this patient developing metastatic disease. I would consider this patient for intensified systemic therapy with chemo plus immunotherapy, if you could do that. The alternative is you take out the renal units, you can do adjuvant, he recurs in the bladder, you take out the bladder, right? I mean, there's a lot of ways that this could progress in a 57-year-old. I don't know that there's a right answer. I think this is a lot of shared decision making here.
Dr. Schmidt, do you see a role for topical installation of any agents, such as BCG, into the renal pelvis?
In a small tumor, in a solitary setting, maybe you could consider something like that. But I think that's kicking a can down the road and not very far down the road. When you have a large tumor like this, you have it in the proximal ureter, you have it in the pelvis. I don't think it's going to work. I think if we have a treatment that can sit in that space in the high-grade setting, like the reverse Thermogel, we know they looked at mitomycin in a high-grade setting a little bit. I think I saw a paper looking at it in some kind of small case scenarios. Maybe there's some promise, but it's certainly not approved in that indication. I think BCG, in my experience in this case, has not been effective. Whether you do it through percutaneous access and drip it down slowly, or you put it in the bladder with a stent, in a patient who was much, much older and really wanted to preserve their quality of life and just delay, yes, maybe, but not in this patient.
So it sounds like, the urologist toolkit is a bit limited in a setting such as this, shy of committing this patient to being anephric and dialysis dependent versus maybe ineffective options like topical installations or futile endoscopic attempts at fulguration, particularly when the volume of disease is high and we know it's high grade. Dr. Hoffman-Censits, do you have any tricks up your sleeves you could offer?
I have a few tricks. I think one of the important things for a patient like this is to really frame what the disease state is and what are the goals of care. This turns out, because you and I have a multidisciplinary upper tract urothelial cancer clinic, that we preferentially will book patients with really challenging disease states that we feel like we both need to see at the same time. No, this is a not uncommon scenario that we see in our clinic. And, I think that I try to imagine, okay, if this patient had 2 kidneys, how would we approach this? Then I have a conversation about perioperative cisplatin-based chemotherapy and nephrectomy going on dialysis, because I think at the end of the day, surgery is still the gold standard. And I think patients need to be aware that choice remains. It's a really tough choice. I wish we had the crystal ball to know who was going to be best suited for that. And the comorbidities that go along with dialysis, all the unknowns, in that setting. And, and then patients ask other really good questions that, well, am I eligible to get a transplant later? There's so many things that kind of go into what does it look like if, I go down that road. And then we go down, well, what would the other road look like, which is if we treat with palliative intent, if the feeling is this is a person who does not want to have their cancer resected, even in the setting where that's an option, then what are our other options? And so that's a situation where I feel like as an oncologist, I can open up my toolkit of medications and see if we can control disease when an operation is not feasible. And so that's kind of how I frame the discussion. And oftentimes this is not just one consultation, it goes on. For patients with upper tract disease, in addition to, having the comorbid, issues and problems with renal function, but the lack of tissue that we have as medical oncologists to oftentimes get additional information like next generation sequencing to see whether or not the patient's a candidate for an FGFR inhibitor. We're limited to some extent by that. So I think for this patient, if they have good renal function, we can use a perioperative toolkit of cisplatin-based chemotherapy. Again, with good renal function, platinum-based chemotherapy with palliative intent with a goal of just downstaging and keeping that renal function as good as we can is also reasonable. And then we also have, this new exciting tool of enfortumab plus pembrolizumab that we can use for patients with, locally advanced and metastatic disease. And that's a great tool for many reasons. So one is, these drugs are not necessarily nephrotoxic, and they are suitable for a wider variety of patients, both, traditionally platinum eligible and ineligible. And the response rates are generally quite high. What is the response in the primary tumor versus in metastatic disease? I don't think we have a ton of prospective or even retrospective data to kind of understand what that looks like. But certainly, preoperative trials are being done. And at least for bladder cancer, I think we'll hopefully be having that information soon. And then if patient has intolerance or progression on our first treatment, there's certainly, the ability to get subsequent treatments down the line. But I think still with the same conversation at each fork in the road of whether or not they want to kind of redecide they want to have surgery at that point in time or not. I think it's important to, if it's still feasible, if there isn't any evidence of metastatic disease, that we continue to have that ongoing conversation if surgery is still feasible.
So this gentleman was vehemently opposed to undergoing a radical surgery, and he wasn't really as excited about some of these other, let's say, topical options that were felt not to be really that effective. Dr. Hoffman-Censits, is there sort of a go-to combination you may use? Are there any clinical trials you can think of that for which he may qualify?
Yeah, well, thanks for asking that one. So as a labor of love, and because I do see patients in my clinic quite often with this scenario, and really felt like this was certainly a population with a huge unmet need. We do have a trial open now at Hopkins using enfortumab and pembrolizumab for patients with non-metastatic upper tract urothelial cancer. Well, really, it is their intention to keep that kidney. So we're looking at, tolerance, safety, outcomes, response outcomes, which are not as, easy sometimes to kind of determine. And then really also an outcome of, can a patient keep their kidney and maintain their kidney function? So we do have that trial open. And I think others, across the country are kind of thinking about using the EV-Pembro toolkit in this or various different settings for patients with hard to manage upper tract disease.
Yeah, and really thank you for your efforts with this trial. I mean, as you had alluded to, it's a very challenging scenario, very much an unmet need for a lot of patients, either between having a solitary kidney or simply being very comorbid or decreased renal function at baseline. Sometimes there is a lot of morbidity that we would put a patient through by subjecting them to a radical nephroureterectomy. And so to be able to show, hopefully in due course, potential benefit from simply a strategy of utilizing systemic therapy alone, that it may be a feasible alternative to surgery, I think would certainly be very useful for a lot of patients that you encounter, in practice with UTUC. And then I guess the last bit, since it is, at this juncture, very experimental, would there be a defined endpoint? Maybe if you can attest to how your what's called the renal retention trial is designed. Is there a certain duration for which you would treat this patient with EV-Pembro, or is it more of an indefinite sort of regimen you would use?
Yeah, I think, the spirit in which EV-Pembro was approved and kind of the thought about how we would give it in this trial is if the combination therapy is controlling disease and patient is tolerating treatment, it's reasonable to continue. What I tell patients when we start therapy, outside of the trial in a metastatic setting, is that, if this combination is working, I think it makes sense to continue. With the knowledge that nobody can stay on enfortumab indefinitely, most patients who are doing exceptionally well on the treatment and are in later cycles, cycle 8, 10, 11, they start to develop cumulative peripheral neuropathy, which necessitates that we dose reduce or hold. And there are other reasons that we sometimes will hold earlier. Sometimes patients can maintain a durable response, whether it's a partial response or a complete response. If it's feasible, if the patient is tolerating immunotherapy, which tends to be easier to tolerate, then we can continue the immunotherapy. Sometimes we stop both drugs if we see something like a high-grade rash. You're not quite sure which drug is causing the side effect. And sometimes we can see a durable outcome without. So just like in standard practice, patients can kind of pop on or off those drugs, ongoing in the setting of the trial, just depending on their tolerance.
Terrific. So ultimately, this patient was treated prior to initiation of your trial, but was in fact treated with fortumab, vedotin, and pembrolizumab. Remarkably, he had undergone a surveillance ureteroscopy roughly after the 5th cycle of treatment, both visually and by cytologic assessment and radiographically as well. In fact, he seemed to be NED despite the burden of disease that he had presented with initially. And so for the moment, he continues on the drug, but I think this is definitely what I would consider very much a wonder drug combination. And I think very excited to see what the future holds as we continue to learn a little bit more about the power of this drug. So only time will tell. But I think, knock on wood, I think he's had a very favorable response to this treatment.
That's remarkable.
So I think we'll go ahead and wrap up, hopefully with one last case for both of our panelists here today. This is a 55-year-old female, no remarkable medical history, very healthy. Initially had presented with gross hematuria, good performance status, renal function well preserved. And on her evaluation for the gross hematuria, she was found to have an infiltrative left pelvis mass, renal pelvic mass. And I apologize, we don't have great representative images from the contrast enhancement, but nevertheless, she was also found to have multiple enlarged para-aortic and perihilar lymph nodes measuring up to 1.8 centimeters in size. I would consider this to be bulky lymphadenopathy. No evidence of any distant metastases, so really isolated to the retroperitoneal lymph nodes. She underwent a ureteroscopic evaluation and had a biopsy performed of the renal pelvis mass that was consistent with high-grade UTUC. Furthermore, I should mention that she did undergo a MAG3 renal scan that revealed roughly 4% differential renal function to the left kidney. So maybe I'll pitch this one, Dr. Hoffman-Censits. You have a patient who presents like this. What would be your go-to next step?
Well, I think, thanks for letting me start. I think importantly, the go-to next step would be this person should be in front of a medical oncologist. I think this is a scan that really worries me, to have this degree of bulky adenopathy. And I can only imagine what we can't necessarily see and what could come out if the patient went straight to surgery. This is the kind of patient that when they sometimes do go to the operating room, that by the time they come to see me and they get a follow-up set of scans, I feel like it's oftentimes, just more metastases. So we really do appreciate the opportunity to talk to a patient like this about chemotherapy. And I think there's a couple of different options. And the way I would look at this is, I would guess that this is probably borderline unresectable at this point. And from a medical oncology standpoint, there's a really large metastatic nodes. So I would be thinking not just about kind of 3 to 4 cycles of neoadjuvant chemotherapy, but more of what I would think of like an induction kind of chemotherapy. So the way I think about that is I'm prepping the patient for at least 6 cycles of chemotherapy. And I want to know sooner rather than later if we're on the right track. So from a perspective of this patient seems like a reasonable candidate for platinum-based chemotherapy, I think that would be an option where, I would write for a full 6 cycles of platinum-based chemotherapy and then make sure I get scans in the middle to be sure that the patient is not just tolerating the therapy, but that we're seeing a significant shrinkage in some of those lymph nodes. I think another option, because this is a tumor that's moved or metastasized to lymph nodes, is a little one of those gray zones of like where exactly is the stage. But I think enfortumab and pembrolizumab is also an option on the table. Would those be used, in sequence if we're not getting an outcome after 3 cycles, I think that, that can certainly be considered. But hopefully this is a patient who can start with some form of systemic therapy, get good debulking from systemic therapy, and then hopefully move on to surgery. I think finally, thinking about chemotherapy plus immunotherapy together that we would use in the advanced settings is also an option. It's really kind of how you're kind of framing this disease, but certainly this is a really worrisome scan with such a young person as well.
I want to hit on what you said about resectable, unresectable. In this scenario, I don't think it should matter. I don't think you should resect something like this. Even whether you can get it out, no matter how good you are, you're not going to help that patient by cutting out those nodes. And this is a perfect example, right? It's a non-functioning kidney. So you could tell yourself, kidney doesn't work anyway. I can get those nodes. You're going to hurt that patient by delaying their initiation of systemic therapy.
Yeah, I'm glad that you highlighted that, Dr. Hoffman-Censits and Dr. Schmidt, for really kind of driving the point in that, nodal disease really should translate to systemic disease and should be treated as such. So be it whether you treat this patient with cisplatin-based chemo or or as you alluded to, the EV Pembro option, what would you say is the role, if there is any? Let's say that this patient received therapy and demonstrated a remarkable response in those nodes. Do we know if there's any benefit to a so-called, let's say, cytoreductive or consolidation nephroureterectomy? Certainly in the kidney cancer world, that's something that has gained a lot of traction and has also been a source of debate over the years. But how about for UTUC? Is there anything that we know about whether or not there's any utility to this oncologically?
There's nothing that I know, but I know we're having these conversations more often now, especially in the bladder cancer. So in not necessarily upper tract, but at least with urothelial, with these patients with EV Pembro who have remarkable responses. And what do we do? Do we take out their bladders? When do we take out their bladders? Can we stop their treatment if we take out their bladders? And so I think we're going to get more clarifying information on this. For me personally, I'd want to see a durable response for at least 6 months to a year before I would consider taking this patient to therapy, knowing that you can get them at least 2 years of therapy before worrying that they're going to accumulate these dose-specific side effects that would be really harmful. I would wait at least a year. And if there's no other disease elsewhere and I thought I could cut it out and decrease the systemic toxicity to the patient, I'd consider it. But I wouldn't do it too soon because, again, I'd worry about delaying them needing the therapy that they need given the high metastatic potential of these tumors that have demonstrated lymphovascular invasion and lymph node metastasis.
Yeah, and I think a big issue here is certainly the lack of data to support the approach, and so I think it's not a clear-cut indication in someone who is metastatic, be it nodal or distant, to sort of offer this paradigm. But like you said, it's still a moving target and one for which I think we need more data to inform how we proceed. What about the role for any other biomarkers? Dr. Hoffman-Censits, there's been a lot of enthusiasm regarding the utility of, for example, circulating tumor DNA. Is this something that you use in your practice and do you perceive utility in this marker?
Yeah, thanks for asking that. We certainly are using it a lot more. I think that, again, another challenge in patients with upper tract urothelial cancers, for the most part, at least the platform that we're using, which is a specific for the tumor itself. It's not a general biomarker. It's a specific for, you send off a piece of tissue and then you get the next gen sequencing as well as the ctDNA. That the patients with upper tract disease often don't have enough to get the ctDNA, so that's an added challenge. But it's a great tool. So this patient, I bet, is symptomatic from this cancer. And so, like we've always had, we use, how's the patient feeling? What does the scan look like? And now, we have the added benefit of adding in the ctDNA to help us, guide the therapy. And again, if we're talking about using EV Pembro to some degree, indefinitely, maybe for a patient who, with a functioning kidney, who had a higher stakes than losing it, then that would be another option in terms of following them along and helping make a clinical decision about this. We don't have prospective data how they use this to manage chemotherapy in the advanced setting. There's a lot more data coming out, but I think it's a tool that a lot of folks are starting to utilize in their clinic.
Very, very interesting and very helpful to know. I mean, it seems like we're now turning, earlier we talked about urinary markers, and now also with circulating markers in the more advanced state. I think there's more and more opportunity to really enhance our toolkit here when it comes to sort of understanding disease burden, prognosis for patients, and even potentially directing therapy. So I will say this patient had a little bit of an off the beaten path sort of route to treatment, maybe a bit controversial. But nevertheless, what had happened is that this patient actually did receive enfortumab and pembrolizumab. And after receiving just 6 cycles, had restaging imaging, which included an FDG PET scan, as you can see here. I didn't show it, but prior to the initiation of therapy, had demonstrated fairly avid lymph nodes almost consistently throughout her burden of lymphadenopathy. In her most recent staging imaging, there was following the 6th cycle of EV-Pembro, there was a considerable decrease in the degree of lymphadenopathy, though there were still some pathologically enlarged lymph node by size criteria, albeit with very mild avidity, so significantly decreased from prior to initiation of therapy, suggestive of at least some degree of response to the treatment, perhaps. And like Dr. Schmidt said, I would say that likewise, I would agree with the sentiment that a more durable response and perhaps an even better response would be warranted before considering consolidation surgery. This was a situation where it was a very nuanced discussion, but the patient was really eager and pushing forth with wanting a consolidation cytoreduction. And so she did ultimately undergo a left radical nephroureterectomy and an extensive retroperitoneal lymphadenectomy as well, following a templated approach. And her final pathology was actually, I would say, to some degree, pleasantly surprising. Out of the 17 nodes removed at the time of surgery, some of which visibly looked enlarged and were concerning for involvement, pathologically, histologically, were all negative. And she did, however, still have YPT3 disease within her kidney. Postoperatively and following her at her post-op appointment, her renal function was reasonably well maintained, a GFR of 72, maybe not unexpected given the split differential renal function from her MAG3 scan. And believe it or not, her oncologist has actually kept her off of therapy at this juncture. Again, perhaps worth discussion at another point in time, I think once we have more data. But she has been now 10 months NED and functionally seems to be doing very well and enjoying her quality of life. So I think just like I said in the last case, there's something to be said about EV-Pembro as a wonder drug, as a wonder combination of drugs. And I think between correlatives and prospective data, where there's going to be a lot to still be learned regarding this regimen, both in the UTUC space and in the lower urinary tract bladder cancer space as well. So on that, I think we had some really exciting cases, really great discussion across the spectrum of UTUC. Dr. Schmidt, Dr. Hoffman-Censits, any additional last comments, any areas that you feel warrant discussion that we haven't been able to discuss?
Not really, but I do want to end on that positive note, like you mentioned with this patient. I mean, this is the first time in a long time we have so much hope in this space. And it's really long overdue, but certainly very exciting.
Yeah, absolutely agree. And happy to see that more clinical trials are being written for specifically for patients with upper tract urothelial cancer. I think it's really important.
I couldn't have said it better myself. And on that, again, I want to thank our esteemed guests, Dr. Hoffman-Censits, Dr. Schmidt. Thank you so much for taking the time and reviewing these cases with us. And thank you all as well for attending and for listening in on the discussion. Appreciate the opportunity to talk about UTUC today. Thank you very much.
Thank you.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.